Good afternoon and welcome everyone to our third presentation in our dysautonomia series. We had some technical difficulties with the video on the last presentation, and so we are re-recording this today. My name is Nancy Barlow. I am the Wellness Coordinator with Parkinson's Resources of Oregon. We're a local nonprofit organization serving people with Parkinson's and their families. We were founded in 1980 and have been doing so for over 40 years in this area. Jean will be discussing tips for navigating cardiovascular dysautonomia with her professional experience and her personal experience. She is a wealth of knowledge. And Jean obtained a Master's of Nursing and a PhD in American Public Policy from the University of Virginia. For 15 years, she worked as a clinical nurse in a variety of settings, including the Children's Hospital of Philadelphia and the University of Chicago. She also worked as a nurse in Switzerland and in Oxford, England, which prompted her interest in healthcare policy. Switching careers in 1991, she held several academic positions, including OHSU School of Nursing. And in 2013, she was diagnosed with Parkinson's disease, and she enrolled later in a research study at the National Institutes of Health, where she learned that she also has neurogenic orthostatic hypotension. Jean is very passionate about sharing this information and helping people understand what this information is. And so we are so glad you're here.
Thank you very much, Nancy. I appreciate your comments. And I welcome you all today to our discussion on dysautonomia. And we'll be talking about some vocabulary words in the beginning part. But let me first start off by saying this picture that you'll notice up on the introductory slide is a demonstration of the sympathetic nerves in a patient's heart. And you'll see very clearly in the initial slide, there is some green and yellow lights. That is the representation of the uptake of the MIBG. It's a radioactive substance that's been injected in this patient, and it shows up in the heart and in the sympathetic nerves in particular. And you'll notice after just a short while, 1.3 years later, there's very little evidence of this nerve activity. 4.3 years, and at 6 years, it's barely discernible. And this is a picture of not my heart, but very similar to what my heart looked like when I went to the National Institutes of Health and had a similar test. It was very dramatic to see physical, biological evidence of the decrease in the activity of a sympathetic nerve over time. So I wanted you to see that and appreciate it, that we're talking about images that are based on science, not opinion. And so this, I think, gives the whole lecture a higher level of credibility and rigor in terms of scientific evaluation. So the goals for this presentation are really to talk about the debate among experts that's going on regarding the definition of Parkinson's. We'll describe some of the costs and benefits of a prolonged period of review before adopting a new definition. I will summarize the 4 basic blood pressure conditions related to cardiovascular dysautonomia that so many autonomic medicine experts argue are common among people with Parkinson's. And lastly, I want to provide practical steps for people with Parkinson's who may have blood pressure instability or cardiovascular dysautonomia and how to manage this condition. So let's move right into what is happening with the definition of Parkinson's. If you didn't know, we're in the middle of a period of transition where for the last 60 years, Parkinson's has been primarily, or in some people claim solely, a movement disorder. And it's transitioning to, we're not chucking the movement disorder part, but we're adding a lot of non-motor symptoms to the definition. It just, how do we do that? What is the organizing principle behind that? We haven't figured out. Here is a slide showing some of the numerous dysautonomic influences that Parkinson's causes. Parkinson's affects the pupils, the brain, different parts of the neurological system, the lungs, the cardiovascular system, urinary system, gastrointestinal, and secretomotor. So that you can see almost every organ of the body is affected by Parkinson's, if indeed the autonomic nervous system is affected by Parkinson's. And I think we have substantial evidence over the last 30 years that indeed that is true. This is an article from Langston in 2006. He's a Parkinson's researcher. He says, now remember, this is 20 years ago. It is now increasingly clear that Parkinsonism, which is the motor symptoms of Parkinson's, Parkinsonism is only one aspect of a multifaceted and complex disorder. Furthermore, it is increasingly clear that at least some of these non-Parkinsonian features can precede the onset of Parkinsonism by years and perhaps even decades. This essay, this article he writes, argues that Parkinsonism represents the disease as seen through the somewhat myopic lens of the neurologist, which he is, whereas in reality, Parkinsonism only represents the tip of the iceberg that makes up this diverse disease. If one accepts this view, then the time has come, he says, to radically rethink the complex of features that constitutes the disorder. So that's one author. Another one, and actually this is an article by two authors. From one is Chaudhry, is British, of Indian descent, and Jenner, I believe, is Canadian. 200 years ago, we know James Parkinson published his observations on several patients who had developed involuntary shaking, weakness, and altered posture. And he called this the shaking palsy. Careful perusal of this landmark essay also reveals the astute observations he made on the behavioral, sleep, and autonomic components of Parkinson's disease, now defined as non-motor aspects of Parkinson's. So today, Parkinson's disease is regarded as a multi-system, multi-organ, multi-neurotransmitter-driven complex disorder with a long prodromal period, that is the early period before symptoms, and this is a concept considerably different even from what we believed 2 decades ago. So again, the notion that there is a transition going on is not something I thought up or just a few people have thought up, but Chaudhry is one of the leading researchers in London to this day. Another article recently in 2021, Parkinson's disease is broadly known to be a movement disorder originating from the reduction of brain dopamine as a consequence of the degeneration of the nigrostriatal system. Developed more than 50 years ago, she claims this definition based on the motor condition is no longer an accurate description for PD. And of all the symptoms that are included, we saw earlier, we saw all these different symptoms that are involved in the I can't even say the word, and the autonomic nervous system. Then of all of them, the most important clinically is blood pressure regulation. It affects so many aspects of our lives. And nevertheless, in 2025, an article recently came out, December. Patients indicate that their non-motor symptoms are not just as bad as their movement disorder, but they are more difficult to manage than their motor problems. And frequent hospitalization as a result of these symptoms is estimated to increase the cost of Parkinson's care 4-fold. So these are not an insignificant addition to the movement disorder. And he writes, despite their frequency and impact, the non-motor symptoms of Parkinson's continue to be underreported, inadequately treated, and there is a need for more clinical trials considering non-motor symptoms as outcome measures. So it's become very, very widely recognized within the field of Parkinson's experts that something has to change. We don't know how that change is going to happen. But what I want to point out is that this has been going on since 1997. That's almost 30 years. And that's, to me, a long time. On average, there is no true average because every medical paradigm shift is unique, but they say the average is around 20 years. So we're already 30 years into this dramatic change in what we understand to be Parkinson's. But what I find particularly troubling is that patients are not included in this conversation. Right now, we're very often treated as if the motor symptoms are their only symptoms of Parkinson's when we're in our clinic visit. And no one seems to talk to us about non-motor symptoms other than perhaps the usual urinary problems, constipation, or a lack of heat, a lack of sense of smell. But in fact, blood pressure, I argue, is something that is so vitally important that it ought to be included in more of our assessment and in our discussions with our providers. So why is it taking so long for this transition to occur and for the definition of Parkinson to incorporate more non-motor symptoms? There's many factors, but one is just human nature. Anytime there's a dramatic change in, especially in the medical sciences, there's a lot of emotion involved. There's a lot of a knee-jerk reaction to reject change. This occurred when Carlson first determined that dopamine is a neurotransmitter rather than just a substance in the brain. And that met with rejection as well. And he was shocked. But that's true of so many things in medical science, that the initial idea is rejected, and then only over time is it gradually incorporated into the corpus of what is considered valid. So, so part of it is because it's normal, but it's taking a particularly long time, I think. So I think it's worth looking at the cost and the benefits. Why do we take so long to review the various aspects of a disease before we say, yes, this is now considered valid? Obviously, research has to be validated. Just one study is not going to be enough to have the whole discipline to accept it as the new given knowledge about that particular field of study. But in the case of Parkinson's, right now we have hundreds of studies. We have hundreds of researchers out there trying to demonstrate that indeed Parkinson's is much more than a movement disorder. But things are not moving very quickly and from a clinical perspective, from a patient's perspective. So there are costs and benefits. One of the benefits is patient safety. You don't want to accept new ideas before they've been shown. But one of the costs is, by delay, what's happening? And I want to emphasize that in today's talk. What are the costs of not accepting or recognizing the impact that non-motor symptoms are having on our patient, on us? And the first thing I want to do is share a personal story that I went through in order to have a diagnosis of one of my non-motor symptoms. I was diagnosed with Parkinson's in 2014, 13. And then in 2014, I developed shortness of breath. And it seemed to me that it was totally unrelated to my Parkinson's. It never even occurred to me that it might be related to Parkinson's. So I started with my family doctor, and he recommended I see a cardiologist. I eventually, over the next 8 years, saw 5 cardiologists, 2 pulmonologists, 2 different neurologists, 2 family doctors, none of whom came to any sort of consensus on what I had. I had numerous tests, cardiac tests, pulmonary tests, all kinds of things to evaluate my heart and my lungs and to see what possibly could be going on. Why was I continuing to get worse with my shortness of breath? And no one could come up with an answer that satisfied them and me. And in fact, I was told by several doctors they thought I wasn't in good shape. And here I was working out with Nancy, my Parkinson's exercise instructor, regularly. And we were definitely working hard. So I couldn't understand why, if I worked so hard, my heart rate wasn't achieving the level that it used to. I can see why my doctor thought I wasn't exercising. But in fact, neither of us knew that was a characteristic attribute of cardiac dysautonomia. So anyway, around 2020, I started doing research as a nurse and an academic. I was familiar with the National Library of Medicine and other sources. And so I started researching studies that sounded like my symptoms. And I found that the National Institutes of Health was conducting a study, and it sounded like my symptoms. So I wrote and asked Dr. Goldstein, who was the chief principal investigator. And when I heard back from him, he invited me to apply for a referral to his program. And I, since they were paying for it, I said, okay. So I went to Washington, D.C., to the National Institutes of Health, or Bethesda, Maryland, and became a study participant. And within a week, he had come up with a diagnosis that I had never heard of. After 8 years, in 1 week, he came up with a diagnosis of neurogenic orthostatic hypotension, which I was shocked at. But what particularly surprised me was when he said it was common among people with Parkinson's. And that started a saga for me, a research saga, to figure out, well, how could this be? On one hand, I was going to some of the best doctors in the Northwest here at OHSU, none of whom could diagnose what was going on. And within a week, a doctor at the National Institutes of Health came up with this conclusion, supported by the image that I showed in the beginning, which demonstrated biologically that I was lacking the sympathetic nerves in my heart. So it was, I decided right then and there, I needed to learn more about this condition, and I wanted to share what I did learn with my friends and colleagues with Parkinson's, and hence why I'm here today. Several years later, I've really spent many hours doing this research and coming up with explanations that I hope will help some of you make sense of some of the conditions perhaps you have. So let's take a look now at some definitions to clarify some terms before I proceed. So one of the terms I keep using is dysautonomia. Dysautonomia is a term that refers to the autonomic nervous system, and that is a system of nerves, a complex system that helps to regulate the functioning of various organs, all the organs of our body, without our conscious input. So it helps to govern our digestion, our heart rate, our blood pressure, our creation of urine, and eyes blinking, you name it. It does all of these things automatically. And so it's called the autonomic nervous system. And so if you're studying dysautonomia, that means something that is affecting the autonomic nervous system adversely. Okay. In my case, I have neurogenic orthostatic hypotension. Neurogenic means it's caused by the nerves. It is not just neurogenic. It's not merely orthostatic hypotension, but it is caused by the nerves that one has orthostatic hypotension. Well, what does that mean? Orthostatic merely means standing up, and hypotension is the opposite of what we're used to hearing about hypertension, which is an elevated blood pressure. So if I have neurogenic orthostatic hypotension, that means I have a condition that caused by the nerves that causes my blood pressure when I stand up to drop. And that causes many, many adverse symptoms. And I also have the opposite syndrome, which is part of the cardiovascular dysautonomia, and that is called this supine hypertension. So, ironically, when I stand up, my blood pressure drops. When I lie down, my blood pressure goes higher. And there's numbers associated with that. So if it goes higher than 140/90, that is, the systolic is 140, diastolic 90, then that is the limits for what they determine is supine hypertension. So what I have is a form of dysautonomia called orthostatic hypotension and supine hypertension. And that is very common. In fact, 40% to 50% of us with Parkinson's have neurogenic orthostatic hypotension. And about half of us also have supine hypertension. There are two other conditions that I want to show you that are also part of the cardiovascular dysautonomia. This is the one that I have, where the main feature is the blood pressure falls because the sympathetic nerves are limited, or denervation of the sympathetic nerves in the heart, and vasoconstriction fails. That means when a normal person without this condition stands up, the blood vessels constrict and the heart pumps harder and our brain gets sufficient oxygen. Unfortunately, when you have the condition I have, and about half of us with Parkinson's have, that doesn't occur, and therefore our brain lacks sufficient oxygen. It may result in fainting, dizziness, loss of sharp vision, sharp thinking. There's many, many symptoms that a result of it's not a total lack of oxygen, but it's a diminishment of oxygen to our brains. And the opposite is the supine hypertension, which occurs when we're lying down, where the blood pressure rises excessively due to a loss of a reflex. This baroreflex is so important. It's one of our most primitive reflexes. It took hundreds of millions of years to develop. And what it does is it guarantees us a normal amount of, an adequate amount of oxygen to our brain, whether we're lying, whether we're standing. That baroreflex is a remarkable reflex that humans have, and very few animals have it. Most animals their dorsal They don't stand up, and therefore their blood pressure doesn't need to adapt to changes in height like we do. And in fact, our head is most vulnerable where our brain is, and because it's the highest point from the ground, when we're standing, it makes it particularly vulnerable to a lack of oxygen to the brain. There are two other forms of cardiovascular dysautonomia. One is called Post Prandial, which means after eating hypotension. This is no surprise. After our meals, the blood pressure drops due to splanchnic pooling. That means it goes to our abdomen. And that's no surprise. The food goes to our abdomen, and so does our blood. And so after eating, we're particularly vulnerable to having hypotension. And at nighttime, this is interesting. Normal persons without any of these conditions, at night when we lie down, our blood pressure decreases by about 10%. But when even if you don't meet the numerical credentials or criteria to be defined as having supine hypertension, if your nighttime blood pressure does not dip, at least somewhat, during sleep, then you are defined to be having a non-dipping episode of blood pressure, abnormal blood pressure. And this is associated with cardiac problems such as heart failure and other problems. So there are four main conditions that are related to blood pressure or to cardiovascular dysautonomia that we should know about because they are affecting us and there are things that we can do about it. So let me just describe what one of them, the NOH, which is Neurogenic Orthostatic Hypotension, carries 3 times the risk of early death compared to Parkinson's patients who do not have NOH. So remember, only about half of us at most have this. It's progressive. It means that if you don't have it when you first get Parkinson's, you may have it in 3, 4, 6, 8 years. So it's definitely worth testing for regularly. And I'm going to talk about that in a second. None of the other non-motor symptoms are associated with survival, like the cardiovascular dysautonomia. For example, the gastric, the constipation, thermoregulatory, urinary symptoms. None of these are linked to survival, like the research is suggesting that blood pressure is. The incidence of cardiovascular dysautonomia among new Parkinson's patients is high. Even if you don't have symptoms yet, or you're just starting with Parkinson's, you may already have this blood pressure problem. You don't have to have had Parkinson's for many years to have it. It can actually be a useful tool to predict the appearance of motor symptoms. If you have REM, sleep behavioral disorder, plus a loss of smell, for example, it's a high prediction of Parkinson's. If you have NOH, that is also, and yet you don't have any symptoms of Parkinson's, that may also be a predictor of Parkinson's. Other long-term consequences of NOH include stroke, heart failure, and 7 times the risk of dementia, as well as atrial fibrillation. So furthermore, 5 times the risk of falls and head trauma are associated with it, and the risk of a hospitalization are associated with this disorder. So if you have NOH, you ought to know about it. You ought to do something about it. You can do things about it. It is not inevitable. So I just want to emphasize the importance of knowing if we have it. So how can you tell if you have it? Well, here I'm contradicting myself. I'm saying here's some symptoms, but in fact, the literature will tell you symptoms are not a good way to tell if you have it. The most common symptom is no symptoms. So even though there's an array of symptoms here, from dizziness, fatigue when standing, difficulty walking, blurry vision, pain running down your neck and across the shoulders, it's called coat hanger pain. If you're confused, foggy, inability to think correctly, feeling fatigue and difficulty breathing, that was my only symptoms for the first several years. If you have any of these, you may well have NOH and not know it. And it's best that you self-manage it. Let me just make sure I am on the right page here. Before I talk about specific steps we can do, I want to just mention, some of the factors why why we don't hear about this. Is it because our doctors don't care? Certainly not. We have excellent doctors. It's a complex answer. Part of the answer is most of our doctors, or many of our clinicians we are seeing, are movement disorder specialists. They have been trained in that specialty. They have not been trained in autonomic medicine. Autonomic medicine, I should also advise you, is a kind of an obscure, very tiny specialty within medicine. Parkinson's movement disorder specialist comprises, there's at least 11,000 members of one medical society alone. There's, I think, 84 in the autonomic medicine category. So the numbers are tremendously imbalanced. And so there's more teachers, there's more research, there's more years of study supporting the notion of a motor disorder rather than a non-movement disorder. So I want to dispel any notion that it's somebody's fault. I think a lot of this is a result of organizational and historical factors. Another factor is that doctors mainly talk about things that the patient brings up. If you do not have a symptom, and again, cardiovascular dysautonomia, I don't know why I can't say that, it typically has no symptoms or no recognizable symptoms. Because of that, if we don't mention something, why would a doctor talk about it? That's when they're busy. Ideally, they would warn us about all the things that we would need to know about Parkinson's. But in the real world, they don't have time to do all that. So it's incumbent on us now that we see the situation evolving where we're not being informed sufficiently to ask questions. And hopefully they will be in a position to give us some answers or to find out answers. So, and another reason why is because of the organizational structure. I sort of implied this earlier. The dysautonomic doctors, autonomic medicine, are very small in number, and they have a very small funding for research, very few specialty centers in the country and around the world compared to the movement disorder specialists. And so, and the way that our medical system is set up for specialists is we have silos where there's a movement disorder silo, which is huge, and they have lots of conferences, and they have lots of money, and they have lots of research and lots of members. And then we have this little tiny silo. There's no incentive for them to communicate and collaborate cross-culturally, across boundaries, across their silos. And so there's more intra-communication going on, but not inter-communication and collaboration. Consequently, just the structure of the medical system and the specialties make it difficult for this information to cross over into other disciplines. And one doctor, Dr. Chowdhury and Lewitt, again, this British Dr. Chowdhury, who's very well known, he is particularly harsh on his colleagues. Now I'm going to read what he writes. He writes that continuing neglect and, quote, a lack of understanding of the key role of non-motor symptoms burden in Parkinson's disease by clinicians, researchers, charities, founders, and policymakers. He considers these to be primary factors in why we do not hear about these non-motor symptoms, specifically cardiovascular dysautonomia. So he's more critical of his own colleagues than others are. He's pretty rough on his peers, and I don't know how they accept that. But I think you should recognize there's a wide range of reasons why this situation exists. I'm not sure it helps to take a critical notion of our clinicians, but I think it's important for us to feel free to ask questions about this and to do the research. At the end of these slides, I have a number of resources that you can look up and talk to your doctors and ask them about questions you may have. So let me go back now and say, what can you do? We've talked about how we got to this situation, and I want us to have some specific tools to take with us to manage our cardiovascular dysautonomia. Self-management might be our best option in conjunction with helpful clinicians. I found not all my clinicians were helpful. Most of them wanted to be, but they didn't have the tools, they didn't have the information. Dr. Goldstein, who happens to be the doctor at the National Institutes of Health, who I was a part of his study, writes, despite the fact that dysautonomias affect over 1 million Americans, you will probably find that very few people and surprisingly few doctors have ever heard of dysautonomias. I believe him now that I've gone through 8 years plus of trying to find doctors. Surprisingly few doctors have even ever heard of it. It may be that no doctors in your area specialize in treating autonomic disorders, but it doesn't mean you cannot get help. So what I'm going to do is review with you some of the things that are in the literature that are recommended that we do to help ourselves. And the first one is, I can't emphasize this enough, take your blood pressure. Buy a nice, good blood pressure cuff that's automatic and that records it online, that you can have a software program. The Omron is the one I'm thinking of, OMRON. They have hundreds of styles. Find one that works for you. And here's a sheet that's in your slides. We can actually send more, I'm sure, that you could record the date, the time, the lying position, the lying blood pressure, the lying heart rate, standing blood pressure after 1 minute, heart rate after 1 minute, standing blood pressure. So what you do, I'm confusing you. When you get up in the morning is the best time to take it. Before you get up, you should, while still lying, take your blood pressure after at least 5 minutes of resting. And then take your heart rate as well at the same time. Then stand up and take your blood pressure immediately, within a minute, both your blood pressure and your heart rate. And keep standing, take it again at 3 minutes total, heart rate and blood pressure. And if you have any symptoms, do that for a week, at least 3 times a day. And that will be an especially important way for you to have documented information to share with a clinician, and so they can appreciate what is going on, because otherwise they're guessing. And if you just take one measurement a day, it's not going to be helpful. If you take it just sitting, you'll notice none of these say sitting. If you take it sitting, that's not going to help because it's the change in position from lying to standing where the abnormality shows up in supine hypertension. I'm sorry, neurogenic orthostatic hypotension. For supine hypertension, I don't have that down here, except you could do it at night, lying down. Just use this line here, 10 o'clock at night. You're lying after 5 minutes, heart rate after 5 minutes, and that's all. Another mechanism, another tool that many of us use is a 24-hour ambulatory blood pressure monitoring. This has to be ordered by your doctor, but most most hospitals have this service, and you would be wearing an arm cuff for 24 hours, and it would be recording in this little machine or something like that, your blood pressure every 10 or 15 minutes, however often they have it programmed for. And that would be very helpful in detecting post-prandial after eating, when you're sleeping, if you exercise, if you're climbing stairs, whatever activity you're doing, you record it, and then the staff can coordinate your blood pressure reading with whatever activity you're doing and any symptoms you're having. Let's review some of the non-pharmacological interventions as well. We should be, because it's important to prevent problems rather than wait for them to arise. If you have orthostatic hypotension, we certainly want to prevent any falling or other problems that can arise. So you should be carefully educated to stand up slowly, especially if you've been sitting in the car or the theater supine for a long time. Well, you don't go to the theater supine, but anyway, when you get up in the morning, patients may pause in the sitting position before standing up. Now, not when you're doing this test. You go immediately from lying to standing, but when you're normally moving around, do it slowly. Another one, avoid heat exposure. Avoid prolonged standing, like standing in line at the grocery store. Alcohol causes vasodilation, which means the blood is going to go out to your extremities, and therefore you're not going to have it going up to your brain. Avoid large carbohydrate-rich meals, spaghetti, pasta, and Valsalva-like maneuvers, such as during urination or bowel movements, like bearing down. Avoid those. Daily routine adaptations, like showering on a chair, and for male patients, avoiding in the seated position, especially at night, because if you're standing up at night, Dr. Goldstein talks about a lot of his patients who fainted at night when male patients went to go to the bathroom. I found this for when shampooing hair or other activities with my hands above my head, I get really faint, or even worse is when I try to blow it dry because my hand is elevated for a longer period of time. And I just am better off if I sit down when I do this, because the blood, again, is not reaching my brain. Always be thinking in terms of, if I'm standing up, what's gravity doing to my blood, carrying the oxygen to my brain? After eating a meal, one is at risk of postprandial hypotension. That means low blood pressure. This is usually only detected when you do this 24-hour test, because most of us are not taking our blood pressure otherwise. And exercise. As we all know, exercise is important for everyone with Parkinson's. Beware of standing while exercising. It's often safer to exercise in a sitting or recumbent position if you think you may have this condition. And especially after exercising, sit for a while. Beware that standing and exercising together, standing is difficult and exercising is difficult to get blood to your brain. Here's a trick. Drink 2 cups of tap water, not salt water or electrolytes, 2 cups of tap water, it doesn't matter what temperature, just prior to exercise, and do it within a couple of minutes, because it will help stimulate the sympathetic nerves, which are missing in our someone with NOH. If you feel weak while exercising, stop, measure your blood pressure while you're in that position. So if you're standing, if you feel really weak, don't keep standing, but if you can manage to get one more blood pressure in, take your blood pressure so you know what's happening. And over time, I've come to recognize when I'm breathing harder is when my blood pressure is lower. So keep your blood pressure cuff nearby when exercising. So these are some guidelines for preventing of problems. Some other guidelines are, this is debatable. Unfortunately, almost all of these have very poor levels of evidence in research. Even though we live by them, we need far more research to give us really good information. Debatable evidence is sleep in a 10 to 20 degree full body head up tilt position. In other words, not just your neck and all, but the whole body should be raised in a head up tilt position. And what that does is stimulate antidiuretic hormone and reduces the pressure of natriuresis. That is, at night when you're lying down, your brain tells your body, if you have a lot of blood flowing through your brain, that you need to create more urine. And so it produces a lot more urine if you lie flat. We should also be wearing compression abdominal binders only when you're standing, not when you're sitting, when you get up from a lying or sitting position, and then remove it when seated. Otherwise, the compression stockings, compression pants have little evidence to suggest their use, even though you read about them all the time. The evidence supporting them is very weak. Abdominal binder, because when you stand up, a lot of the blood in your chest goes into your abdomen, and there's a lot of room in my abdomen to stretch. And so that's why they say keep that binder on when you stand up, because it's easier to accumulate blood here than in your legs, because your arteries and veins are not as big in your legs as they are up here in your abdomen. Some non-pharmacological measures, we should stay very well hydrated, up to 2.5 quarts a day. Many doctors recommend salt, but if you're on heart medications, you might want to check with your doctor first. And I think we just talked about that too. Non-pharmacological interventions if you are symptomatic. So if you're having a problem and you feel lightheaded, sit or lie down immediately. Don't waste any time. Even if you're in the grocery store, I'll just sit on the shelf or sit on the floor if I need to. In case of an inability to sit or lie down, perform these blood pressure rising maneuvers, such as walking in place, step purposefully, crossing your legs hard, tense the gluteal and abdominal muscles in your gut, bend forward, or clenching the fist. Any of these activities will help to promote venous return and get blood go back up to your brain. The real problem is you're not getting oxygen up to your brain. And I'm very cognizant of that all the time. So, in conclusion, the science behind Parkinson's disease is in flux. Cardiovascular dysautonomia is the most serious non-motor disorder among Parkinson's patients. Finding clinicians who listen and value your concerns is more important than whether they have an autonomic specialty. It's not necessary to find a neurologist or movement disorder specialist to assist in diagnosing blood pressure instability. It may be useful to find a specialist in autonomic medicine, and if you find that to be true, there are numerous institutions in the U.S. with such specialties, including Stanford, Vanderbilt, New York University, and the Mayo Clinic. And here are some sources and directions on how to select the blood pressure cuff. So I am happy to have talked with you today, and I have a list of questions that people have submitted that I would be glad to review. I wish I had you here in person, but this is the next best thing. So I'm going to read the question and then give a quick response. Is it possible that a person with Parkinson's can't get his heart rate or respiratory rate elevated with exercise? I'm not certain how vigorously this person exercises. The answer is yes. My cardiologist thought I wasn't exercising very hard, but I have since found out that indeed it's called chronotropic incompetence is very common among people with cardiovascular dysautonomia, because the heart, we don't know why. Let me say that. I won't go into it, but that's very common that as the older you get, the longer you've had this condition, the less your heart rate, your heart responds, both in terms of how strongly it pumps and how quickly it pumps, because the sympathetic nerves and the baroreceptor are no longer as strong as they should be. Okay, question 2. I've been reading lately about the benefits of cold for resetting the autonomic nervous system. Have you heard about this? Can cold be used to bring the blood pressure back up? I have heard that too, actually. But I think I don't know the answer regarding Parkinson's. I just would suggest what I mentioned earlier, 2 cups of water, doesn't have to be ice cold. It stimulates the sympathetic nerve response. So it could be that cold does it as well. I don't know. There's a question about PSP, which is a subtype of Parkinson's disease. Is it a silo? I would consider it a subset of a movement disorder. I don't think it would a silo is an informal term I'm just using, so I wouldn't want to assign it to that. Should patients with cardiovascular dysautonomia regularly have kidneys, heart, or brain tested for damage? I would say there's no guidelines that exist currently, but perhaps it wouldn't hurt to have some sort of baseline testing, but you'd have to find a doctor who'd be willing to order that. Are there Oregon doctors focusing on cardiovascular dysautonomia? I wish I knew some, but I don't. What about Washington? There is one doctor in Washington, and I can't say his name offhand, but there are 3 certified doctors who have a certification in autonomic medicine in California, mostly San Francisco Stanford Hospital. Where can I get an abdominal binder? The name you can look up on Google is Copper Fit. It has a little copper coloring on it. Who should I see if I have supine hypertension? So should I see a regular cardiologist? You could, although my understanding is cardiologists are looking for something different than autonomic specialists. Autonomic doctors look at the autonomic nerves. Most doctors, cardiologists, nephrologists, family doctors, neurologists are not looking at the autonomic nerves. So you could go to a cardiologist or nephrologist, just recognize, you might ask them, are they comfortable talking about autonomic nerves? Should we use a wrist or an arm blood pressure cuff? And the answer for that would be wrist is not as accurate as the arm. How rapidly do these dysautonomias develop? Well, they can develop over several months or 2 years, and they're progressive, which is one reason why they're difficult to pin down, because they get worse as you're dehydrated. If you stand up, then it shows up more than if you're just sitting. So they're constantly, just as when you're moving constantly all day long, and your baroreflex is adjusting, you don't have a baroreflex, and so you're going to have symptoms off and on throughout the day if you have several of these characteristics. Like you just ate a meal, you are dehydrated. That doesn't make sense. And you're hot. If you do all that, you're going to have more symptoms than otherwise. So it might feel like it's developing all at once, but it's really just the symptoms are changing over, depending on what precipitating factors there are. Is the time of day important when taking orthostatic blood pressure? Yes. As I mentioned before, in the morning it's most dramatic because you're more likely to be dehydrated. If you're dehydrated, you don't have as much blood volume returning to your heart and thus to your brain. How do you encourage the education of medical providers and long-term care providers? Have you any advice for a patient whose doctor exhibits strong resistance to learning about this new thinking? Well, if somebody's has strong feelings about it, I wouldn't bother trying to dissuade them or change their mind. I'd try to find somebody who is more congenial, perhaps, but maybe sharing professional literature and just asking questions. How comfortable are they treating and talking about this dysautonomia? My carbidopa-levodopa controls my blood pressure. I tend to have good pressure when on, but when I'm off, it goes through the roof. Is there a night-only medication? Yes, there is. I take a night medication when my blood pressure goes up at night. It's called captopril, C-A-P-T-O-P-R-I-L. It only lasts about 8 hours and it's out of your system. What to do before a stress test? I'm assuming it's a cardiac stress test or an exercise stress. In either event, be sure to hydrate well. And like with any exercise, anytime you're going to be standing for a long period, quickly drink down 2 cups of tap water within like 3 minutes, and then it'll last about an hour to help keep your blood pressure up. So that's the end. It's been very enjoyable talking with you, and I wish you all well. Bye-bye.
Thank you so much, Jean, for sharing your time and your expertise. We're very grateful.
You're welcome.